Appreciate you coming out. You all hear me okay? Yes? No? Yes? Yes? Well, thank you very much. We're not going to talk about everything spine because we only got an hour or so, but we'll talk about most things and kind of translate that into what happens in the neck and the lower back. The thoracic spine is a kind of a whole different animal. But we'll talk tonight specifically about lower back problems. Degenerative disc disease in the lower back, spinal stenosis. Who here has spinal stenosis now? Good. Get my card on the way out. No, just kidding. We'll talk about all those, the treatment options that we have for all of that, and kind of tell you where we're going and what kind of things are available to you, so we know what kind of, where we're on the same page. So, back pain, degenerative disc disease, lower back pain is the second most common reason for physician visits. The most common reason is neck pain. Second most common is back pain. So when we look at back and neck pain, it's a large population. 90% of the population at some point in their lifetime will have back pain. Who's got back pain right now? Yeah, me too. Yeah, no, just kidding. Just kidding. Lower back pain, about 15 to 20% per year. About 15, or more than that here tonight, of course, because we have a very selective population here tonight. But 15 to 20% of the population has back pain at any time in the year. So it's a lot of us, almost 1 in 4 of us have back pain throughout the year at some point. And the treatment costs, we hear a lot about how much things cost, about $50 billion related to treatment of back pain. So it's a big number when it comes to healthcare costs. And a lot of that's related to the surgical costs, how much these implants cost, and screws and rods and bone grafts and all those kinds of things, how much those go into that. So we look at one of the most common patient populations, those over 40. A lot of us here over 40 now, yeah, yeah. Most of us over 40. Who's under 40? Maybe that's a better question. Yeah. I saw you raising your hand. Under 40. It's a normal part, right? We all age with time. Well, hopefully we age with time. We get some arthritic change in the lower back, but it all varies. Some of us will have an x-ray that looks horrible and have no back pain. Some of us have a great looking x-ray but have severe back pain. So the variety of pain doesn't specifically relate to the x-ray findings. There are some things that do accelerate that process though, vibration. Who can think of a job that has a lot of vibration in the back? What was that? Truck drivers. Truck drivers, the biggest thing. And if you ever get in the older trucks specifically had some very bad seating. The trucks now is almost like a lounge chair in there, easy boy kind of thing that takes that vibration out of there. But a lot of the guys now in construction work, doing crane work, that kind of stuff where they have to lean over to get a lot of vibration, those haven't really caught up as of yet. So a lot of vibration can affect the lower back. Repetitive bending and lifting, a lot of things we do, manual labor kinds of things, lead to bending and lifting and injuring our backs. Smoking. Smoking's a big one, causing back pain, causing arthritic changes in the back. We're learning more and more about how smoking affects how oxygen is attached to the blood cells and then doesn't get into the middle of the disc. And the disc dies because of the lack of oxygen. So smoking is a big reason for having back pain. One of the biggest things you can do to stop your back pain is stop smoking. We get you to stop smoking, that may help your back pain quite a bit. Male, who's here is male? Just, you don't have to answer that. Male gender. Heavy lifting, of course, the bending, the turning, that kind of stuff, and stressful occupations. Stress obviously is a very subjective thing. Different jobs have different types of stress, not particularly physical stress, but mental stress, that kind of thing. But it's really the stressful occupation that limits what we can do, how much we move. So these are the kind of the conditions we'll talk about. Degenerative disc disease, that's that wearing out of the disc or the arthritic change in the disc itself. Spinal stenosis, which is a product of that degenerative disc disease. As the spine wears out, we get some closure around the spine, a pinching of the nerve roots, the spinal stenosis. Degenerative spondylolisthesis. Listhesis, can everybody say listhesis? Yeah, it sounds like you're lisping, right? Slipping. Sounds like a slip. That's spondylolisthesis. It's a slippage of the bones. Degenerative scoliosis, that's this big curve that we see here. Generally, we see that from the front view, and it looks impressive. You see that big curve from the side view. We got to think we're three-dimensional animals, so as we twist and turn, we also bend forward, and that causes that scoliosis, causes you to bend forward as well. A little-known facet joint arthropathy is the small joints that are actually in the back of the spine that get irritated and can pinch the spinal nerves as well. So what are the discs? The discs are those pieces of cartilage that are actually between the two bones. So if we look at the vertebral body, the bone that's here, and the bone that's here. They kind of articulate. They come together in the back, called the facet joint. We just mentioned that, the facet joint arthritis. These are the small joints that are here in the back. But the disc is this space that's here. About 20 to 30% of the height of the spine is related to the disc. We have lots of discs between a cervical spine and a lumbar spine. As those discs wear out and collapse, we lose some of our height because those discs are almost a third of the height that we have already. What is that disc made of? Well, we see this little model here on the right, and we flip that over, so we look at the disc that's here. On the outside of the disc is a annulus fibrosus. It's a very tight fibers that are on the outside that allow the bones to be shifted and moved without cracking or breaking. So that annulus fibrosus is very, very strong. In the center here is a soft part, like the inside of a jelly donut. Who likes jelly donuts? Yeah? Not this jelly donut, but another one. So the nucleus pulposus is this soft material that's in the middle here, allows it to be squished, allows it to be moved from side to side, as well as that annulus fibrosus maintaining the bone's position so they don't shift and they don't move. As we age, that annulus fibrosis, that covering of the disc, will get a little bit of a hole in it, a little bit of a tear. And that nucleus pulposus can leak out and pinch the nerve root. So you get a piece of that disc that leaks out and pinches that nerve. That's a herniated disc. There's a couple of different terms we use. We call herniated disc or disc extrusion. They've heard of disc extrusion, a piece that comes out, or propulsion of a disc. Herniated disc, extruded disc, propulsive disc, they all mean the same thing. It means that the disc is actually ruptured or pinching back. That's the other thing. Ruptured disc, pinching back on the nerve root. Disc bulging is the disc degenerating. So the disc kind of bulges out, similar to pressing on top and bottom of a marshmallow. The disc kind of bulges out on either side as it wears out, kind of collapses down a bit. So it may or may not compress a disc herniation like this that ruptures out and pinches the nerve root. A piece actually comes out of the disc. Generally, in our elderly folks, who's going to admit they're elderly? No, just kidding. Who's elderly? In our elderly folks, as that disc wears out, that nucleus pulposus gets more fibrotic. So it's not that squishy jelly donut in the middle anymore. It's more fibrous tissue, a little bit more stuck together. But the annulus, the outer side, gets more weak, so it can allow a piece to come out. Most of those acute disc herniations, the piece coming out, rupturing, happens in that 30 to 50-year-old population. As the disc is in that in-between stage, it's not a very plump, healthy disc. The 20-year-old, it's not the older disc that's worn out a bit and kind of stuck where it is. In that over 50-year-old, but at 30 to 50, where the disc is starting to wear out a bit, and that annulus is wearing out a bit, and it allows a piece to come out and pinch the nerve root. We do get some fissuring and tears to that annulus. That's that older disc that allows it a little bit of a tear and allows a piece to come out, allows a piece to rupture or pinch the nerve root from the side. The annulus, that covering of the nerve, is weakest on either side, right through this area here and through this area here. There's a ligament on the back we call the PLL, or the posterior longitudinal ligament, that runs straight down the middle of our spine in the back, but on either side, unfortunately, right where the nerve root is where that annulus is the weakest. So when we rupture a disc, it ruptures generally right against that ligament and to the side, right where the nerve root is. That's why we get a pinched nerve related to a disc herniation. It doesn't have to be a big event. Some people have a disc herniation rolling over in bed at night. Some people picking up something heavy. It doesn't have to be big, a big event to cause a disc herniation. It just has to be at the right position at the right time. The disc being a little bit tweaked at the time allows a piece to come out and pinch the nerve. So what does that look like? This is an MRI scan here from the top down. The disc is in the front here. Here's the nerve, the disc herniation into the spinal canal. So that white area there is the spinal canal, and that's the disc herniation that's actually ruptured back and pinching the nerve roots in the spinal canal. Most of them actually are asymptomatic. What does that mean? Well, most of us, if over 40, if you're going to admit you're over 40, about 40% of those patients over 40 years old on their MRI scan will have a disc herniation but no pain. It's pretty incredible. When we think about disc herniations, we always think, well, I need surgery right away, I have a disc herniation. Likelihood is you won't need surgery. If you took 100 40-year-olds and did an MRI scan of their back and they didn't have any back or leg pain, 40% of them, almost half of them, will have a disc herniation but not have any pain. It's an impressive number. Something to keep in the back of our mind. The symptoms also vary on the direction, so it depends on where that disc herniation is, where in the body it is, up and down, which level it is, as well as which side it is. So a disc herniation on the right side causes right-sided pain. Does that kind of make sense? A disc herniation on the left side does not cause right-sided pain. So it's a kind of a way to think about where the nerve roots run, where the disc herniation actually is. Why do we get sciatica, or that pain down the leg? Because of either mechanical or inflammatory problems. So the mechanical thing is actually that pinched nerve, the rupture of the disc that's pinching the nerve, putting mechanical pressure on the nerve, rather than the inflammatory change. The inflammation that's there because the nerve root got hit. So you bruise your arm, you get irritation in the arm, you get swelling, that's sore, but you probably didn't break your arm. If you break your arm, it hurts, right? That's a mechanical problem. Same sort of thing in the back. You rupture the disc, you break the disc, it hurts. If it pinches the nerve root, you get that pain going down the leg. If it's just irritated, you also get pain down the leg, but it's just inflammation, just irritation that's there. So either one can cause that problem. Degenerative disc disease, rather than disc herniation or disc rupture, is that loss of height due to dehydration. So each of the discs, if we look at the side view here of a model of the spine, the disc that's here in the middle is the best disc that's on this model. The height is pretty good. Starting to develop some bone spurs there. And you can see where the nerve root is right next to that bone spur. So as the disc continues to collapse, that nerve root gets crushed, gets pinched right into there. So that's that bulging disc, not actually a disc rupture, but a bulging disc that's pinching the nerve root that's there. That transition from the liquid to a more solid, the jelly donut becoming less jelly in the middle, having more fibrosis or more, the material in the middle getting tighter, getting less liquid or dehydrating. So the degenerative disc disease. Spondylolisthesis, remember we said listhesis together? Say that again, it's fun to say. Listhesis, yeah. It's fun to say. The spondylolisthesis, spondylo means spine, and listhesis means slippage. So it's the forward translation of one vertebral body on another. So if we look at the x-ray here from the side view, these bones are lined up on each other, very normally. This bone here does not line up with that bone there. That's that slippage, that spondylolisthesis. If you look at the disc height that's there between the two bones, looks pretty normal here and here, but not so normal there. You guys see that? So that space there between the bones is not as tall as it should be. That allows the bones to kind of slide forward because you're wearing out that disc space, so it slides forward, that spondylolisthesis. The other issue, or the other way to get spondylolisthesis is we call spondylolysis. So spondylolisthesis is that slippage forward where the bone slides forward. Spondylolysis is actually a crack in the bone. So rather than a degenerative change, you get a crack in the bone. Generally happens in younger patients. We see it almost in 1/4 of our athletes, especially those that do gymnastics or those that are linemen, especially down linemen in football, where they do a lot of arching of their back. They can break that bone. It's actually the growth plate that gets broken when they're doing those kind of activities. So when that breaks, that disrupts the connection between the front of the bone and the back of the bone and allows the bone to slide forward, that listhesis or slippage forward. You can get some fibrous tissue, some tissue that's in between the two bones. It allows it to be more stable, so it doesn't really shift around quite a bit, but it can be more stable. So most of those kids, when they come in, have this crack, don't ever need surgery because those bones will become stable with time. Spinal stenosis, again, another reason for having pinched nerves. If we think about the spinal canal as this carrying of the nerve roots behind the bones, so each of the bones are the squares and the discs are between. We think of that sort of a water hose. So your brain's being up here as the faucet, allowing the water to go through your spinal canal. If you pinch off that water hose, that's fluid that's coming through the end there doesn't go through as quickly. That kind of makes sense? You can turn up the water hose as much as you want, but if you're pinching it, you're not really going to get a lot of fluid down there. The similar thing happens in spinal stenosis. If you look at this x-ray here, this is a myelogram, so there's a little needle here that puts dye into the spine. You can see areas here behind the disc where there's not much dye. That's the fluid is not flowing well through the spinal canal. So the information trying to get from your brains to your legs makes your legs achy and tired, slows you down. so that you don't walk as well, you don't walk as much, and you want to sit down more often, so that information will catch up with you, makes your legs tired. This is what that myelogram looks like here from the front view. You can see what that means. So the dye is white. There's not much dye here, not much dye here. You can see on there. So that dye, that flow of fluid through the spinal canal is much tighter, so the information is slowed down as it goes through the spinal canal. So how do we look at patients? We've got sort of a general basis of the knowledge, the glossary of ideas. How do we take a look at these patients? Well, similar as we do to anybody else. We're going to look at their history, their physical, do some imaging. We saw some things, x-rays, MRI scans, that sort of thing. And then we're going to figure out the right treatment. We want to know from the patient what makes their pain worse. What kind of things? Lifting, carrying, pushing, pulling, leaning, turning, bending over, rolling over at night. What makes it worse? Also, what makes it better? Doing dishes, that makes my back pain. Yeah? No. Vacuuming, it really hurts. Yeah. Eating dinner out makes my back pain better, right? Yes? Yeah, good. So we're all on the same page then. Yeah, good. Numbness and tingling. We want to know whether or not there's neurologic compression. Is there pinching of the nerve roots, getting numbness and tingling down a leg? Which leg, which toe, back of the leg, front of the leg, all those sorts of things. Weakness is a big thing. Can you go up on your toes, go up on your heels? That weakness that's in the feet specifically, getting up and down from a chair. How far do you walk? We talked about the walking, that information going from your brains to your legs, slowing you down. When that pressure is on your back in spinal stenosis, you walk 2 or 3 blocks and you got to sit down. You can't walk through the mall anymore. You got to sit down because your legs are tired. When they catch up, they get tired. Bowel or bladder problems, so when you get severe stenosis, then it affects your bowel and your bladder. What kind of medications you're taking, other medical problems, especially diabetes, heart disease, peripheral vascular disease. So patients that have peripheral vascular disease will have that same problem when they walk. Their legs get tired, they get sore and achy, and they sit down. It's a different process, a different problem, but you the physician needs to know which one it is and try to help differentiate for you. Is it your back or your legs that's causing you not to be able to walk as far? The physical examination is also important, the kind of things we want to look for. We want to see what your back looks like, what's your neurologic exam, provocative testing to see if the nerves get stretched or pinched when you move in certain directions, to help us figure out what's going on, and rule out other reasons why. This patient here has a spinal fusion here and came to us because he still had significant hip pain, a lot of groin pain, still a lot of hip pain. If we look here closely at his x-ray, he's got no cartilage in his hip. So he's had 2 surgeries on his back, but he needed a hip replacement. That's that kind of thing. So you want to make sure the physician is taking a look at these things. If you're sitting on the table and moving your hip and it hurts, it's your hip, it's not your back. So you want to make sure that he's looking at these things. The vascular problems, kidney disease. If he's got kidney problems, kidney stones causes back pain, as well as arthritis causes back pain. So we try to figure these things out. Make sure your specialist is take a look at all these things for you. Make sure you don't need a hip replacement. Spinal metastasis, this is the zebra in the room. When you hear horse hooves, it's a zebra. This is if you've got a tumor, if you've got some cancer in your back. Very rare, but you want to make sure if all your imaging study looks okay, then you need an MRI scan, you need a CAT scan, you need further studies to figure out what's going on with your back if you're still having pain. In our physical exam, especially on the neurologic exam, each we call dermatomes, each spot on the body we know where the nerve root comes from. So if you tell me you've got pain going down to the side of your foot, that's the S1 nerve root. So I can figure out on your x-ray or on your MRI scan what I expect to see. When those things correlate, then we say that's the problem. It kind of brings that together. We can correlate your neurologic dysfunction, your reflexes, as well as your weakness and your sensation in your foot, or in your arm for that matter, and be able to correlate that with your imaging studies, and be able to be more exacting where your pain is coming from. Speaking of imaging studies, we always get an x-ray, always get a plain x-ray to look at the bones. Patients always ask when they come in and they have had an MRI scan or a CAT scan, they need to have an x-ray. The x-ray really gives us a good view of the spine. It can help us rule out some simple things like tumors, those kinds of things, or kidney stones can be seen on a regular x-ray. You can figure out a lot of that kind of stuff just by the plain films. So always to get a regular x-ray, despite the MRI scan, the CAT scan, make sure to get a regular x-ray as well. The MRI scan is looking for nerve and disc in the bone marrow, so it can look at the nerves, look at the disc and see the actual disc as opposed to the x-ray, which sees the outline of what the disc looks like. But it could also look at the bone marrow as well. So if there's changes in the bone marrow, like we'll see a fracture in patients with osteoporosis, so you can break a bone, but the x-ray will look normal. The MRI scan will show us some subtleties there of changes in water flow that's in the bone marrow. We can see a fracture on an MRI scan. So we mentioned about a third of those asymptomatic patients will have an abnormal MRI scan. So if those patients that come in that have an MRI scan that say, I have a herniated disc, but I'm having no pain, they get no surgery, right? So we want to correlate those imaging studies to what the MRI scan says. Just as our neurologic evaluation will make sure that pinched nerve on the right side is causing the right pain in the right leg. So correlating all that together. Myelogram, we'll show you some pictures of those, as well as discography. That's not something from the 70s, that's an imaging study. And then we'll try to bring all that stuff together to make information here. So on a regular x-ray, from the side view, we can see the bones at each level. We can see the outlines of the disc, but we can see there's a slippage in the bones here. We can take an x-ray with the bend forward and bend backwards and see those bones actually shifting backwards and forwards, something you can't see on an MRI scan or a CAT scan because we're actually having you move. You can see those imaging studies and see that on a plain x-ray. So this patient here from the front view, see you've got a bit of a scoliosis. Again, won't see that on an MRI scan because this shows us an overall view of the bones. And then the slippage here of the bones, the stair step there, those three bones, L4, L5, and S1, slip forward there when she bends forward. So that slippage of the bones better seen on an x-ray. The MRI scan is important though, don't get me wrong. When we do MRI scans, we're really looking for these disc herniations. We put up what looks like a normal MRI scan here on the left side. The bones are the squares here, and the discs are between, nice and white. That's the water that's in the disc. That the cartilage holds that water, allows the bones to be pliable, be mobile. When they lose that water, that's that arthritic change that we call black disc disease. The disc is wearing out. So losing that water, losing its pliability, becoming more fibrotic, and you get a disc that's bulging here and ruptured here. So you see that disc pushing back there, and that pinches the nerve root. It fills up the spinal canal. So it's good to look and see what a normal one looks like and what an abnormal one looks like. The myelogram, this is, we put a needle into the back. Who here has a myelogram in the past? A couple of folks have had a myelogram. The MRI scan has really gotten us away from doing a lot of myelograms now because obviously the MRI scan doesn't need a needle in your back. So you get an MRI scan. There are some folks that can't get an MRI scan, people with pacemakers specifically, or those folks that have brain aneurysm clips. Those little pieces of metal can move. Hip replacements, knee replacements, fractures, hip fractures, that kind of stuff, do not need to withdraw from an MRI scan. You can still have an MRI scan with a hip or a knee replacement. Spine surgery, neck surgery, those kinds of plates and screws that hold the bones together will not move in an MRI. All right, does that make sense? So you still get an MRI scan. So the myelogram, we put a needle in the back and we fill that spinal canal with dye, that fluid that's there. We can see on this myelogram there's this area of spinal stenosis. So the dye flows nicely through here. Actually, you see it coming down the nerve roots on either side. But right at this level, it gets pinched off. We call that wasting of the spinal canal, like the hourglass shape. The spinal canal gets pinched off there. So we know that's spinal stenosis. The discogram is another fun study. This study, we put a needle into the back, especially into the disc, and then we fill the disc with dye, and then we expect this patient to scream. So much fun. The discogram is really one of the only tests that we have to correlate imaging studies with pain. So as we said, in the MRI scan, about a third of patients will have a bad-looking MRI, or they got a disc herniation but no pain. This study here is trying to correlate those issues together, especially for back pain. So if we inject that dye into the disc and the patient screams and says, that's the pain I'm having all the time, doc, that's it, then we know that's the disc, that's the problem. So we can get that, we can figure out what to do with that specific disc. We also see the degenerative changes. We can also see the dye that comes out of the disc, so the disc kind of doesn't hold the dye, so there's a hole or a way for that dye to get out of the disc. So this is what that looks like here. So we've injected these three discs that are here. These are nice normal discs here. This one's here is kind of flat and the dye is kind of going towards the back. There is a number of patients, we do more than one disc at a time, not because we think that's fun, but because there are a number of patients, about 20% of patients, that will have discs that are irritated by the dye. So we do an injection of the dye into the disc, even a normal disc, and they scream. So this is painful. So there's about 20% of those patients we say is a false positive. So we got to be careful about how we interpret these imaging studies on the discogram. Again, correlating the MRI scan, CAT scan, discogram with your physical exam to figure out where this pain is coming from, try to bring it all together so we know what the best options are for you. So how do we treat you? Generally, we start with conservative treatment. We want to try to get you better without having to operate on you, right? Yeah? So we try to do a couple of things. Bed rest maybe a couple of 3 days, but really not very long. We really want you up and moving as much as you can. Anti-inflammatory medications, sometimes some narcotics for acute exacerbation, but we really want to try to stay away from the narcotics as much as possible. Antidepressants, not because you're depressed, but because the antidepressants also stop back pain. There are some we use, Cymbalta is one, Elavil is one, that actually work on nerve pain or back pain that are antidepressants but help with the pain. Sometimes a brace, we try to stay away from braces as much as possible. Diet and exercise, exercise being the key. We want to try to get you better by moving those muscles and tendons. There's been a couple studies now, actually 4, a while ago, looking at bed rest, because it used to be we'd tell you go to bed for a week, and when you're at that week's time, you come back and see me and you'll be better, right? The 2 aspirin, call me in the morning, go to bed for a week and you'll be better next week. There is no evidence that that actually works, so we don't tell people to go to bed anymore. We try to get them to move as much as they can. Bracing. This is from West Virginia. Who's from West Virginia? Yeah. All right. West Virginia bracing right here. Duct tape does everything. Even your braces, right? No, just kidding. So bracing. So bracing doesn't prevent anything. We see all the guys at Home Depot and Lowe's wearing a brace. It doesn't prevent back injuries. It makes them think about their backs, but it doesn't actually prevent back injury. It makes you feel better, though. Sometimes if you got back pain, having a brace on can be helpful to help you get up. We use them after surgery because it helps the muscles hold together and makes you feel better getting up, but it doesn't actually prevent back injury. The medications, we talked about those anti-inflammatory medications or opioids, narcotics. There's actually been a study, several studies, this is from the UK, but several studies looking at narcotics versus Motrin. Motrin and Aleve, was, we have that over the counter here in the United States, but over there they've got all kinds of things that they can use. The narcotics don't work any better than Aleve or Motrin for back pain. Sounds weird, doesn't it? As soon as I have back pain, I want a Vicodin, I want a Percocet, I want a Valium. When something to get rid of this stuff, it's not going to work any better than the anti-inflammatory medications. So there's several studies now looking at how we manage back pain medically. How do we manage back pain physically? So physical therapy program. This is actually a study that was done in 1998 looking at booklet versus chiropractics versus physical therapy. And this is a pain diagram for their disability score when they started out versus where they ended here at 104 weeks, so a couple years after their back pain. The booklet, what does that mean? That means when you come and see your primary care doctor, your orthopedic surgeon is not really concerned about you, say, here, take this book, do some exercise, you'll be fine. Doesn't really work very well. Chiropractic treatments and physical therapy, if we look at these, the triangle and the little open dot there, they all get better with time. Why is that? The chiropractor and physical therapy talk to you. They want to make sure you're feeling better. They do some ultrasound, they do some massage, they do some exercise, they get you moving again. They tell you you can do it. Going to your doctor and just saying, here, you do some exercise doesn't help you. You still go out of there with back pain. Now I got to do an exercise that hurts. Right? So going to the physical therapist, going to the chiropractor is very important. A lot of our patients say, well, I don't need physical therapy, I can do it on my own. Likely, yes, you can do it on your own, but having a physical therapist work with you, making sure you're doing the exercise correctly, doing some of the touchy-feely massage, oh, that's good. TENS units, all those kinds of heat, ice, oh, the big heat thing they got upstairs, oh man, it's awesome. That makes you feel better, gets you feeling better, and then you have someone to talk to get through the back pain so they can get you through this issue. So what do we do for the non-specific lower back pain, people that hurt their backs and come in to see us? If we're not suspecting anything bad, we try to maintain their normal activity level. So try to be as active as you can, going to work, being as active as you can, maybe not doing all the heavy lifting, that kind of stuff, but being as active, being as mobilized as you can be. Non-narcotic things, Aleve, Motrin, there are some specific ones that we use prescription-wise that are easier to take, easier on your stomach, less side effect profiles on them, but non-narcotic pain relievers. That way you can be active. You take a narcotic and a Vicodin and a Valium, you're out, that's not going to help you. So we want you up and want you moving. Aerobic fitness, so getting out and doing some walking. You don't have to be at the gym, but at least doing some walking, maybe be in the pool, that kind of thing, to get some aerobic fitness. Stopping smoking, we mentioned that before. Trying to stop smoking, or at least cutting down your cigarette use or your tobacco use. That will also improve your back pain. And then weight loss, getting rid of the beer gut will help your back. Right? It kind of makes sense. You're taking less weight across your spine, or across the discs that are there, it makes you feel better. The natural history of sciatica, when we actually have truly sciatica, truly a pinched nerve by a disc herniation, that natural history is actually very good. When we look at the leg score versus the VAS score, which is the visual analog score for pain for the back of the leg, you see about 25% or 25%, a quarter of those patients will still be having significant pain at 12 weeks. So at 3 months out, most of those people, 80% of people, are better by 3 months. So most of those people are going to get better. These people here we'll talk about in a minute about what to do for them, but at 3 months you're going to be better. Your pain is going to be better. You will get better. It's not at 3 months you're always better, but you will continue to improve. Your pain will get better. Trying some of these non-operative kind of things first. Those people that don't get better, what do? Well, that's when you come see me. We talk about surgery. Not surgery at home. Do it yourself. We want to do some operative things. So this is for ages 5 and up. Everybody here 5 and up? Good. A couple of things we want to try to do surgically. We want to decompress the neural elements. That means taking the pressure off the nerve roots, whether disc or bone spurs, ligament that's there, anything that's pinching the nerve root, we want to take that pressure off. We want to make sure the bones are stable. So if they're slipping or moving, they need to be stabilized. You need to hold them in the position so they don't pinch the nerve roots. And then correcting any deformities. So scoliosis or curves there in the back, either front or sideways, we want to correct that deformity, get you back on track again. Now we need to pause a little bit because we're talking about disc surgery or pinched nerve surgery versus back pain surgery. Back pain surgery is notoriously not good. So there's several studies here that we call the most controversial area of spine surgery. Fusion, doing surgery for fusion for back pain is a 50-50 shot. We're just flipping a coin, see if we can make you better. So we put you through lots of treatments prior to that. Hopefully you'll be in that group that gets better without surgery. When you don't get better, then that's when we can think about surgery. This is a procedure called an axial lift. It's actually a screw that's put up toward near to the rectum and then through the disc spaces that are there. There's lots and lots of different ways to try to fuse, especially the lower spine, for back pain. The reason why there's a bunch of different ways to do it, there's another one here called axial lift from the side. Put in the little cages and plates there from the side. The reason why there's so many different ways to do it, because they all work exactly the same, 50-50. You may get better, you may not for back pain. So little pause there. Nerve surgery works extremely well. 95% of people are going to get better with nerve-related surgery. Back pain surgery, not so much. Does that make sense? All right. So if we're talking about surgical decompression for disc herniation, surgical treatment, we've got 3 studies here, is better than non-surgical treatment. There's a big study called the SPORT study. Has anybody heard of the SPORT study before? No. No, just me? Good. Okay. That was done in Maine, where everybody's locked in there in the snow so they can follow them very closely. The SPORT study looked at disc herniation patients that had disc herniation over a 10-year period, and randomize those patients to having surgery or not having surgery. Those patients that did not have surgery, about half of them went to the surgical group because they wanted to get better. The surgical group got better with surgery. So the surgical group works better, gets better, faster than patients that don't have surgery. So disc herniation surgery, as opposed to back pain surgery. We talked about 50-50. In disc surgery, spinal stenosis surgery, exactly the same as well. So spinal stenosis, pressure on the nerve roots, pinching the nerve roots, slowing down the information from your brain to your legs, that surgery works extremely well, getting you back on track again. So how do we do that? There's a couple ways to do that. This is the surgical game here. We do this. Well, this is from medical school here. I just put that up for you to look at. No, high voltage, of course. We do the laminectomy. Everybody heard about a laminectomy before. That's removing the lamina, taking the pressure off the nerve roots. So we go in through, remove a bit of the bone so we can decompress the neural structures, or taking that pressure off. Fusion for instability, when those bones are shifting backwards and forwards. We talked about the back pain not being so hot, but only after non-operative things have failed. So you've tried all these other things and you're not getting better, or you've got some neurologic problem that's getting worse that we need to get you to operating more quickly. This is the laminectomy. Everybody's had something to eat already, right? Yeah, you're not grossed out. Good. So looking at it from the back here, this is called the spinous processes here, and on either side is the lamina. So we're going to take out the spinous process and the lamina. When we do that, we're looking right at the nerve called the dural canal. So this is where the nerve roots run through here. There's a covering of that called the dura that holds the nerves together and allows that fluid to flow around the nerve roots. This is a big cyst that's here that's pinching on the spinal canal. There's a big bone spur and a cyst there that's squeezing that. You see, you kind of see what that looks like, that pressure that's there, that spinal stenosis. So we're going to take that out. When do we fuse patients? When do we put screws and rods in and hold the patients together? When there's a slip, when the bones have already slipped and the bones are unstable, or they've got scoliosis, that curve in the back, we're going to do a laminectomy. It's going to make things more unstable, either with the spondylolisthesis or the scoliosis. We're going to take out some of that bone. It's going to make it a little more unstable, so we want to put screws and rods in. Or if we know the type of surgery we're going to do is going to make you unstable, then we need to put in screws and rods before we leave doing that surgery. If we're going to make it unstable, we've got to fix it while we're there. Or if you've got a recurrence of a stenosis or discretion. So if you've had a laminectomy before and now the stenosis has come back, you need to have a fusion this time. The reason the stenosis came back is because the bones continue to move and they continue to bulge. The disc continues to bulge and pinches the nerve roots. So this is what that looks like. We just put in screws and rods. This is at L5 and S1. Screws go into the bone called pedicle screws. They go into the bone and they connected with a rod in the back here that holds that together. This is what it looks like in a model, so you kind of get an idea from the back. We remove those spinous process, right? The laminectomy, that's all been removed here. And the screws are put on either side, 2 screws at each level, and then a rod that connects everything together. There has been some recent episodes of having just screws put in on one side, and it's a way to save money, but it's for hospitals to save money. But if we're there, we're going to fix both sides. We're there to provide stability, so we want to hold the bones together. What kind of things can happen in surgery? Well, if you don't plan well, right? If you got the wrong surgery, the wrong surgeon, or the wrong diagnosis, then you're going to end up with this kind of a problem. You haven't planned well. So an error in surgical decision making, if all those kind of things don't come together, if your leg pain doesn't correlate with your MRI scan, the stenosis doesn't correlate with that, then having a surgery in your back is not going to help your peripheral vascular disease. So we want to make sure that everything correlates so the decision making is proper. Intraoperatively, there's a couple things that can happen. The dura, that covering of the nerve roots, is right next to the spinal canal. Sometimes that arthritis will press on there or make it very thin and can cause some rupture of that dura, or that allow the fluid to leak out. We repair that at the time of the surgery. Not a big problem, but it's something that happens in the operating room. A hematoma, that's fluid or blood that's after surgery that can build up around the spinal canal. Generally, we use a drain after surgery to get that blood out of there. So it's not a big problem. The battered root, that's in the patients that have had multiple surgeries. They've had that nerve root moved around many times, and now that nerve root's not happy anymore. It doesn't want you to touch it anymore. So that you end up with a neurologic problem. There's some sciatica or pinched nerve kind of sensation down the leg, even though there's no pressure on the nerve root anymore. Scarring. This used to be considered a problem, epidural scarring, but we know everybody scars. There's very few that actually have a scarring problem. That we used to blame a lot of the bad surgery on epidural scar, that we'd say, the reason why you're still having pain or still having a problem is because of the scar tissue that's built up. It's very unlikely that that's actually the problem. There's probably something else going on pinching the nerve root again rather than scar. Hardware complications, of course. If you're putting in screws and rods, you can put them in the wrong place or you can put them in the right place. So we want to make sure the guy that's putting the screws and rods in knows where they're going. Patient-related factors, we talked about some of those, especially smoking. Smoking is the big one. In patients that smoke, the likelihood of healing goes down. So infusion rates with pedicle screws after surgery, that fusion rate's about 90 to 95% of those patients are going to fuse, are going to heal. With smoking, that goes down to 70%. So if you smoke before surgery, smoke after surgery, you will have a less chance of healing, skin and bone. So that may lead you to having another surgery done because you didn't heal. That's the big one. So hopefully we've given you an overview, and now you have all the directions, which way you cannot go. Giving you an overview of the management of lower back pain, degenerative disc disease. Questions? Anything that I didn't cover that someone wanted to know that I missed? Yes, ma'am. Good question. She asked whether or not, how does osteopenia or osteoporosis affect screws and rods? Osteopenia generally does not affect the screws and rods. We like to know beforehand, so we do a bone density study prior to putting in screws and rods and make sure that the bone density is adequate. Osteopenia generally is not a problem. We just change the size of the screw that's going into the spinal canal to get a better hold. In osteoporosis, that can be a problem. So we want to make sure that we can address the osteoporosis prior to having the surgery done. So that means increasing your calcium uptake, sometimes using Fosamax or calcitonin to get the bone stronger prior to having surgery. So good question. Yes, sir. Arthritis, we talked about here. There's a couple of things. The arthritis, the disc that's bulging, can pinch the spinal canal, pinch the nerve roots. The bone spurs that are there from the facet joints or the arthritis can pinch the spinal canal. Or those bones that are slipping, that listhesis. As the bones slip forward, it pinches the spinal canal. That's the spinal stenosis. Exactly right. So that's the bone spurs that build up inside the nerve canal and pinch the canal, or the disc that's building up and pinching the canal, bulging and pinching the canal, or the bones that are slipping that are pinching the canal. Yeah. Not some kind of a plaque. It's an arthritic change that happens there. Exactly. Yeah. Exactly right. Yeah, there's only so much room for the spine, for the nerve roots that are there, so that when the disc bulges or the bone spurs develop or the bones slip, that area gets much smaller. So that's narrowing that area, smaller area, smaller size. Yes, ma'am.
Why does spinal stenosis hurt so much at night?
Good question. Why does spinal stenosis hurt so much at night? It's a neurologic issue. Anybody had carpal tunnel before? Carpal tunnel wakes you up at night. You've got to shake your hand. It's a neurologic issue. So the nerves are active even when we're sleeping. At night, you've got to shake your hand because that neurologic, the same thing happens in the spine. When the nerves are being pinched, they're still active at night, but they're waking you up because of the pain. Yeah. Yes, sir.
If practice like this practice here, you have more than one doctor that does the same type of surgeries, you consult each other?
Do we consult each other? Generally, no, because generally we know what we're doing most of the time. There are times when there's a big procedure, that kind of thing, that we want to get another set of eyes on it. Yes, so yeah, we would. But generally, it's the most common things we wouldn't. There's some very few, like tumor cases, that kind of stuff, that we would have the other guy just look at it and say, "What do you think? Is there any other things that I should be thinking about?" But generally, fellowship-trained spine surgeons know what they're doing. And can make it through most of it. Yeah. Yes, ma'am. Yes. Uh-huh. Uh-huh. Right. Ah. Well, she's asking, she had surgery back in 2001 for the same pain in your arm. Yeah, and now the arm's about to fall off, so we'll try to put the arm back on for you. No. That pain redevelops, that tells us that you may have another pinched nerve. It may be the disc above, the disc below, depends on the type of surgery you had done. Yeah, and bone bank surgery is notoriously not good. Unfortunately, a lot of that bone bank surgery did not heal. These days, especially in the cervical spine, we use plates and screws to hold the bones together because the bone graft generally didn't heal very well. So without plates and screws, generally the neck bends forward a bit and can pinch that nerve root again. So it would be prudent to get a new imaging study, either X-ray or MRI scan, to see where things stand now, and then help us decide about where to go from there. It may be a simple injection rather than having to have surgery. Yeah. Well, then it's time to get it fixed. Yeah. Yes, ma'am. I'm sorry, right here. She was far.
My question is on OSC.
Yes. I know those people, yes.
Various areas, and you make an appointment. It seems like everybody's all doctors specialized.
Mm-hmm.
Well, what happens if you go see a doctor, one doctor, and actually another problem,
Yes, she's asking whether or not all of us are specialized. We all have things that we do as specialties, but we all see everything. So your knee pain, back pain, hip pain. I'm a back guy, but I will take care of your hip and knee until they need a surgical intervention. If they do, then we'll get my partner to take care of that for you. Most of the time, again, orthopedic issues, most of the time you don't need to have surgery. You need a therapy or an injection or medication to keep you going, to keep you out of the operating room. And all of us will be able to do that for you. This is surgical stuff that we separate out. When it's time to get surgery, then we'll get you the right guy to get that done. Yeah. Sorry, yes. She's asking about whether or not this is laser surgery for degenerative disc disease. Yeah, well, she's asking about incision size. The incision size depends on what you're getting done. The simple microdiscectomy, just taking out a piece of disc on one side, is a 1-inch incision. You go home the same day, 45-minute procedure. The larger surgeries, the big scoliosis surgeries, can be a 12 or 18-inch incision in order to get the bones to where they're supposed to be. So it depends on what you need. I would be very cautious in laser surgery. Lots of laser surgery is not good. We've seen several patients from a group in Texas and a group in Florida now that have come back here for their real surgery. Unfortunately, it's kind of the red flag when they tell you it's cash up front to get this surgery done. It's not covered by insurance because it doesn't work. Depends on type of surgery. If you have a microdiscectomy, a small outpatient surgery, be back to work in a week or 10 days. A big lumbar fusion kind of surgery, maybe 4 weeks to 6 weeks. Yeah. What's that? Which surgery? It depends on the size. Again, if you have a long scoliosis fusion, a 2-level fusion, probably be about 4 to 6 inches. Yeah. Black disc disease, yes. Yeah, she's asking about black disc disease. That's a sort of a slang term that we use for that, what we see on the MRI scan. That MRI scan, we'd like to see that disc to be nice and white and plump. It tells us it's got full of water, full of fluid. When the disc becomes arthritic, it starts to age, then it starts to lose its ability to hold the fluid, and it looks black on the MRI scan. So it's called black disc disease. It's an arthritic change. We can't make the fluid go back in. We can't add fluid back to that disc. Yes, ma'am. Okay. Yes, ma'am. I'm sorry, with spinal stenosis? Why do you get pain relief only when you lie down with spinal stenosis? It may be the shifting of the bones that's doing that. If your spinal stenosis is related to the bones shifting, when you lie down, they shift back and they open up the space. So really probably need the X-rays, MRI scan, see where things are, and we may be able to give you some answers to that. But most likely it's the shifting of the bones. Yes, ma'am.
Is there anything else that can cause the black
Disc disease? No. It's arthritic change. As that disc loses its ability to hold the water, hold that white that we see on the MRI scan, that disc is worn out, so that water is white. When it loses that water, it turns black. It's just the image that's on the MRI scan. Injections, injections for the epidural steroid injections that we do are generally for disc herniations or pinched nerves. So they work best for neurologic pain, the pain going down the leg, the sciatica, or the neck of the arm. This lady's asking about her neck. Doing injections around the disc in the neck stops that inflammation, the irritation of the disc itself on the nerve. It's quite variable, actually. Sometimes it works for several weeks, sometimes several years. We have folks that some folks come in and get an injection a couple times a year. That's all they need. Some folks, it works for 24 hours and they're back and saying, it's killing me, cut me open, fix it now.
Okay, so the only cure for that kind of injury is fix it.
For which injury? Herniated disc, no. As we talked about, there's about 80% of those patients that are going to get better in that first 3 months. So if we can get you through that inflammatory change, that irritation of the nerve root, the injections help decrease the inflammation, the exercises help move the nerve root around, get the back stronger. You get through that and you're not in that 22% of people, you're going to be fine. Yeah. Yes, sir. Right. He said he had 6 screws and pins put in his back, and his feet are still numb. As we talked about, there's several different reasons for that. So one of those can be the vascular disease, the blood flow to the legs causing deterioration of the nerves. Most commonly, neuropathy. Diabetic neuropathy is the most common, where the diabetes, the sugar that's in the blood, affects the ending of the nerve roots and makes the feet numb. So a nerve study would be helpful to try to figure that out, see if that's actually coming from the back or is it coming from the nerves outside of the spine. We call it neuropathy. Yes, ma'am. How far are we from the use of artificial discs? We do those here now, actually. The artificial discs, especially in the neck, work extremely well. Unfortunately, there are not many insurance companies that cover it so far. In the neck. In the back, there's only one that covers disc replacements in the lower spine. Right now, the FDA has only approved disc replacements for one level. So you can have one disc replacement put in. Most of the patients with arthritic chains are going to have more than one level. So it's mainly younger patients that have a single level disc herniation, single level disease. Yeah. So spinal stenosis, spondylolisthesis, the slippage of the bones, doesn't get better with a disc replacement. Yes, ma'am. L5 to S1, we did one today in about an hour. So L5 S1 fusion, how long does it take? About an hour. We did also this morning a 6-level osteotomy, big surgery, takes about 3 hours. So it's a good question, and you should ask your surgeon that. Unfortunately, there's lots of guys that take 6 hours to do a single level fusion. You don't want that. Just ask them how long it takes to do a surgery. If it's 6 hours, go somewhere else. It should take a single level fusion, an hour, 2-level fusion, hour and a half. So it shouldn't take that long. You shouldn't be losing a lot of blood. We don't expect you to need a blood transfusion after surgery, especially for the general 2 or 3 level fusion that most patients do not need a blood transfusion after surgery. We do use a call a cell saver to recycle your blood in the operating room. We use that about 10% of the time to recycle. We don't generally lose enough blood to give you any of your blood back. So we don't expect you to lose enough blood from that type of a surgery. So if they're talking 6 hours, 4 hours to do a single level fusion, that's too long. Yes? Spinal stenosis. She's asking whether or not spinal stenosis can present as a non-painful condition, but weakness in the legs. And yes, it can. It's a pinching of the nerve roots, and most commonly, the three things that nerve roots contain are sensation, numbness, tingling, pain, and then motor function. So if the nerve root gets pinched, it just irritates the motor function side of things, and you can get some weakness. We've got to be a bit careful, though, because you may have weakness in your legs related to stenosis in your neck. So you won't have pain in your legs, but if you've got pressure on the nerve roots in your neck, you find that you walk kind of funny, you can't feel your feet, it may be from your neck rather than from your legs. So a good physical exam will figure that out. Yes, ma'am. How long does the fusion surgery last? Lifetime, yes. Yeah, we don't expect to be back there, especially if you don't smoke. The smoking is the big one. If you smoke, then you may be back to get another surgery because it didn't heal the first time. But if everything heals, we don't expect you to be back for any more surgery. There has been a misnomer about spinal surgery that I hear every day. If I have spine surgery, then I know people that have had 4 or 5 spine surgeries, and so they tell me never get spine surgery. If you've had 4 or 5 spine surgery, the first one wasn't done right for you. We expect your spine surgery to work well the first time and don't expect you to be back to have anything else done. Yes, ma'am.
I have some pain down my right leg, some tingling and numbness. When I sit down, it goes away. When I stand up, just 5 minutes so it really gets bad.
Yeah.
And I would think when you sit down, it would be better.
I'm sorry, you said it was better when you sat down.
When you sit down.
Right.
It's better when I sit down.
Right.
Stand up, it's better.
Right.
So shrunk 4 inches.
You're shrinking 4 inches. Oh my God. Wow.
So the spine is
Yeah.
compressed.
Yeah.
So that's probably why.
Yeah. So she's asking, she's got pain and numbness in her right leg when she's standing for any length of time, a few minutes, but when she sits down, it goes away. That's classic spinal stenosis. The nerve root gets pinched when you stand up. If those bones slip, as you're talking about, the bones slip and pinches the nerve roots, you get that pain going down the leg. When you sit down, it opens up that space around the nerve roots, it goes away. In peripheral vascular disease, to kind of correlate those, that pain it starts to get bad in your leg and you sit down. It takes a while for that to go away because it needs to clear. The blood flow needs to come back again. So that takes a lot longer to go away than the spinal stenosis kind of a pain. Yes, sir. Generally not. He's asking compression fractures, they cause the same kind of problems. They generally don't. The compression fractures generally happen in patients that have osteoporosis or not strong bones. So the bone's kind of soft anyway. So if it pushes back into the spinal canal, it's not enough to cause stenosis, generally. There are some patients that have that, mostly car accidents, stronger bones that take more force to break. Yes, ma'am. Uh-huh. Okay. Uh-huh.
And so, should I wait for 30 days to go back?
Are you still having back pain now? Okay. So she's having back pain and went to her doctor and they gave her a month's supply worth of Vicodin. It doesn't seem to be helping. You need to go back, yes. Yeah, don't wait a month and then see what happens. Go back and see if there's any other options for you. Yeah. Yeah.
The numbness and tingling in my leg, is that the same as mine?
Yes, ma'am. Yeah, the numbness and tingling in the leg, generally going down the back of the leg to the foot, is sciatica. Whole leg, yeah. There are some thoughts of people say, well, I have sciatica in my butt. Well, no, that's just butt pain. Yeah. Probably because you're married. No, just kidding. Yeah, that's why I have my back pain. No, just kidding. So the pain down the leg pain, especially going the back of the leg to the foot, that's sciatica. So hip pain, buttocks pain is not sciatic pain. That's not neurologic pain. I feel like I'm neglecting you guys up here. Yes, sir.
I'm the slow learner.
Oh, okay.
Surgery
Yes. Yes, he's asking whether or not there are alternatives to surgery for spinal stenosis. And yes, so they talked about several of those things. Physical therapy programs, injections, medications, all to decrease the irritation that's there around the nerve roots and open up that space. So yes, we would try all that stuff prior to getting you to the operating room. Yeah. Yes, ma'am.
I think I have cervical stenosis and spinal stenosis. I've had 5 bulging discs in my lower back and in my neck. And I don't know when my back hurts whether it's coming from the lower back or my neck. And is there anything, I mean, other than injections in both spots?
She's asking whether or not back pain and neck pain are correlated, and actually they're not. Back pain and neck pain are separate. Neck pain does not cause back pain, and back pain does not cause neck pain.
But when you have both bulging discs in your neck
Right.
and in your back, in your lower back.
The correlation that's there is actually 25% of patients that have a surgery on their lower back will end up needing a surgery on their neck because of the arthritic change that's there. So it means you've got arthritis. So you've got arthritis in your neck, your arthritis in your back, and both of them need to be managed differently and separately. Yes.
Say you have an injury and you have neck and back pain. An injury causes neck and back pain. I heard you.
Yes, an injury can cause both neck and back pain, yes. But what we're saying is back pain does not cause neck pain, and neck pain does not cause back pain. But yes, if you fall off a building and break your back and your neck, both of them hurt. Yeah. Yes, ma'am. All right. Okay. She's wanting to know why there's more than one opinion for what needs to be done in your back. Honestly, it's because each of the guys is only comfortable with doing one procedure. That's the honest opinion. Is that they've not been trained to do the variety of procedures, so they're comfortable doing one procedure, and they're going to do that procedure because that's really all they know how to do.
Well, it's strange because it's the neurologist that wants to do the infusion,
Yeah.
and the orthopedic surgeon that wants to do that.
It doesn't matter either one, but well, again, it's really what they're comfortable with doing. If they're comfortable doing laminectomy, that's what they're going to do. You want to get a third opinion. Get someone to look at it and say, you know what, this is what you need. You need a fellowship-trained guy to look at it that's done all of them before and knows how to fix you. Yeah, you don't want to have a surgery again later on. I'll be happy to take a look. Be happy to take a look. Yes, sir. Back row, bright shirt. Yes, sir. Yes, sir. He's saying he has epidurals and they seem to last 6 or 8 months, but then the pain comes back. It's really up to your tolerance what you want to do. If you want to continue to get 2 injections a year, there's no downside to doing that. If you're fed up with it, you want it fixed, and we'll get it fixed. Yeah. Yes, ma'am. I'm here on Thursday and Friday this week, so talk to ladies here. They'll set you up for Thursday or Friday. So, yeah, our policy here in the office is you get to be seen when you want to get to be seen. So you call up and say, I need to be seen this week, or I want to be seen next week. I'm going to Rome. I'm not going to be here till July. Fine, we'll see you in July. But whatever works out for you, I'm here Thursday and Friday. I'll be happy to see you here next week, whatever works out for you. Yes, sir.
How long do these last?
How long does a CD last? Is if you don't step on it, it lasts forever. Okay. Yes, I saw. Yeah. Why do they help back pain? They modify the nerve sheath. Why do antidepressants help back pain? They modify the nerve sheath, so the covering up the nerve root. Anti-epileptics the same way. We see some of the anti-epileptics are used to stop seizures. but they also help decrease back pain because they stop the irritation of the nerve sheath, the covering of the nerve root, so it helps to stop the back pain. Yeah. Yes, ma'am. Disc replacements in the neck. On the back, the lower back. The old workers' comp's the only one. Yeah.
Somebody if anybody had a birthday today.
Who had a birthday today? Anybody have a birthday today? This week? Anybody have a birthday this week? You got one this year? Who's got a birthday this year? Bunch of smart Alex, I tell you. Why I oughta. To the moon, Alice. How about this month? Next week? February. Who's got it in February? February? 26, all right. You win. Winner, winner. 27th, we got 27th. 3rd of March, okay. 27th. It's all my fault. That's true.
So enjoy.
Thank you. All right, yes, ma'am. We got one more. Yeah. Of course. Any other questions? Good group of folks tonight. Good questions. Yeah. We'll put some of this on our website so you can. Yes, ma'am. Yes.
If someone did have an injury,
Yes.
younger,
Yes.
would you, after having how many injections, would you say, okay, go ahead and have surgery, or you can wait 5 or 10 years down the line after having a lot of injections? What would a doctor's recommendation be?
Yeah. Well, it's not an easy question to answer. There's lots of variables in there, specifically the MRI scan, what the MRI scan looks like, and where that's going for you. Most of the time, and it's sort of a general kind of way to think about that, most of the time if the back or neck is what's slowing you down, we fix the back or the neck so you keep your back in track. We really don't want you stop exercising because of your back pain or you're getting unhealthy because of back pain. So we would try to get you fixed prior to that. Yeah. Yes, sir.
I've been told I need a knee replacement.
Uh-huh. Right. Okay.
Is there any particular item to do which should be done?
Yeah, he says he got a bad knee, needs a knee replacement. He's also got spinal stenosis and needs to have surgery on that, which the order that we do those in. And there's two answers to that. One of them is the amount of pain you're having from either one. If the knee is what's slowing you down more than the back, then we get the knee fixed first. If the back is worse pain-wise, then we'd get the back fixed first. Overriding that, if they're about the same, we'd start from the ground up. Get your knee better, and then get your back better. Yeah. Yes, sir. Uh-huh. Mm-hmm. You can remove a Baker's cyst and it comes back. He's asking about Baker's cyst in the knee, in the back of the knee. Generally, you draw fluid out of it, will come back. There's really no use in continuing to take fluid out of a Baker's cyst. I don't know why they're doing that to you, but it's terrible. So no reason to do that. It promotes infections by having the needle put in that thing so many times. The other way to treat that is to do a surgery on the front of the knee, an arthroscopy, to open up the space, the hole that allows that fluid to go in and out. The Baker's cyst is that fluid collection in the back of the knee, and it collects there because there's a one-way valve, a tear in the medial meniscus that allows that fluid to go back into the back of the knee but doesn't come back into the knee joint itself. So you need to open up that tear, take that out so it allows the fluid to flow again. Taking out the Baker's cyst will not make it go away. Mm-hmm. Yeah, it shouldn't be repaired, it should be removed. Yeah. Yes.
When I turn my neck, I can hear it pop.
Mm-hmm. When she turns her neck, she can hear it pop. You got Rice Krispies in your neck. Yeah. Is that bad? It's not bad. No, it's. My mom used to tell me that I cracked my knuckles, I was going to have arthritis, and I got real. No, just kidding. No, it's not true. Yeah, not true. Old wives' tale, old dad's tale. I don't be sexist, you know. Yeah. Yes. Any other questions? Great. Well, thanks for coming.